And we can come to the last speaker. Thank you, Simo, for doing the job. Which is Professor Alberto Gabizon from the Hebrew University in Israel. And he will talk about and introduce us into the EPR effect.
Thank you, Jan. Thank you to Beat and the organizing team for inviting me to come here. My presentation will be also a biological presentation, and I will be talking to you about the EPR effect and its relevance to nanomedicine in the context of cancer therapeutics. I hope I will, yeah. So just a quick picture to show you what is the image that can be seen when conventional liposomes are injected into a human being with liver metastases. As you see here, this is the, yeah. As you see here, this is the normal liver scan of these patients, and you can see that when you inject the colloid in those places where there are no reticuloendothelial system cells, they remain white because they don't take the radioactive material. And actually, the image that you get with these conventional liposomes is a superposing image. So this is just to show you the site where we were, or the place where we were many, many years ago. Clearly, the reason for that is the fact that, as you well know, the Kupffer cells take up the liposomes extensively, and they lead, therefore, to a concentration of the liposomes in normal liver. Now, just to jump into the stealth liposome era, this is the picture you get when you inject intravenous radiolabeled liposomes that are pegylated liposomes, what we call stealth liposomes. And this picture from Dr. Frank Martin shows a patient with Kaposi sarcoma, and you can see his lesions are, of course, are seen all over in the skin, in the chest, and even in the face. And what you can see here is that when you follow the liposomes, the radioactive liposomes, you see, first of all, that initially there is a big blood pool image. So most of the liposomes are circulating in the central compartment. And as the time passes by, when you go to 24, 48 hours, you see that the liposomes start to concentrate in areas where the tumor sits, where the tumor resides. And this indicates a beautiful deposition of liposomes. This is what we are looking for, definitely to deliver an anti-cancer drug to this tumor. Of course, KS, Kaposi sarcoma, is really the hallmark of the high hypervascular tumor with high vascular permeability. And clearly, as you will see later, tumor intervariability is a major barrier in what we can achieve with nanomedicine. Just a reminder of size and where we are. And this is a liposome. This is an antibody which is 10 times shorter in diameter, and a single molecule of doxorubicin. And clearly size matters. Not all nanomedicines are the same. And in fact, as I'll show you in an example of a paper by Dr. Rakesh Jain, 12 nanometer nanoparticles do not behave like 120 nanometer nanoparticle. And because of the importance of the EPR effect, about 1.5 years ago, there was a meeting at the NIH in which we tried to look at what could be the challenges ahead in looking at the EPR effect and its impact on nanomedicine drug delivery. And this was published later in Cancer Research, the conclusions of the meeting. And I will go a little bit along the lines of the discussion that we had in that meeting with some updates. And as you see, enhanced permeability and retention effect, as you well know, was initially described by Dr. Hiroshi Maeda in some hepatic tumors. Hepatocellular carcinoma is a highly vascular tumor, and Dr. Maeda did important experiments in regional chemotherapy of these tumors, and he found out that these tumors indeed show this type of effect in which there is macromolecules and nanoparticles can enter the tumor interstitial space due to the enhanced permeability of the blood vessels, whereas the suppressed lymphatic filtration blocks the clearance from the tumor. So this was actually more than 20 years ago, and not many people paid attention to this. But the more we know and the more we work with nanomedicine, we see that this is a critical effect in the way in our success or failure with nanomedicines. And in fact, EPR is a hallmark of tumor neovascularization, and we could say that it is the basis of nanotechnology platforms. Blood vessels indeed are the Achilles heel of cancer. And as you see here in this cartoon from a paper of Mitchington and Ian Tannock, a normal blood vessel and the neoangiogenic tumor blood vessel differ in many ways. There is incompleted endothelial lining in the tumor blood vessel. There is a lack of lymphatics, many things like compression by tumor cells and dilated microvessels, and many alterations which happen especially at the place where the primary tumor develops. And the processes that are encountered when we look at the efflux of liposomes or nanoparticle extravasation in tissues with increased vascular porosity, the processes are of two kinds. One is the convection processes, which is really a dominant process for these nanoparticles. And it is really the gradient that you get between the vascular, intravascular pressure and the interstitial pressure in the tissue. Of course, as Dr. Maeda has shown in some beautiful experiments, if you increase blood pressure, especially if you do intraarterial regional chemotherapy, you can, of course, push much more nanoparticles into the tumor by this convection process. There is also, of course, a diffusion process, which has to do with the difference in vascular concentration and interstitial concentration, and which is a slower process. And, of course, the diffusion processes, the longer the particles will stay around and the higher the concentration in blood vessels, the better the rate you will end up getting of diffusion into the tumor. This is just another cartoon that I use a lot to illustrate, especially for the young scientists, the EPR effect. Normal tissue, there is a very tight endothelial lining. Tumor tissue, fenestrated endothelial lining. Active lymphatic drainage in normal tissue, no lymphatic drainage in tumors, and therefore these nanoparticles, they start actually extravasating and accumulating in the interstitial fluid, and gradually they release the drug, and the drug then can move across, because it is a small molecule, it can move across various tumor cell layers and kill the tumor cells. Of course, there is also a washout effect. Some of the drug may go back into the blood vessel and be washed out. And one of the advantages that active targeting may have is that by internalizing liposomes or any other targeting nanoparticles and releasing the drug intracellularly, the washback of drug may be diminished. And therefore, this could be an advantage, but still EPR remains critical also for actively targeted system. And the fact that you put a ligand will not really let you skip the need for EPR effect. And this is another typical image that was obtained actually by Dr. Timo van Hagen in Erasmus Medical Center with some liposomes that we sent to him in a tumor model. And you can see here, this is the skin fold window chamber, and you can see that when you look at the fluorescence of the liposomes, you see a gradual increase in concentration of the liposomes. And this is really massive, in fact. If you look at Doxil, the prototype nanomedicine formulation that exploits the EPR effect, you can see that in this tumor model, this is a control tumor, this is a tumor injected with free doxorubicin, and these are mice that were injected with Doxil, and you can see with your naked eye the huge concentration of drug accumulating in the tumor and in the surrounding tissue. And if you measure these, you can see that the concentration in the tumor of drug is almost 40-fold greater than the concentration of drug in skin, which is only a couple of centimeters away from the tumor. So if these were always the case, clearly the battle against cancer would be much easier. But let me give you a few more facts that relate to the EPR effect. First of all, it has been shown also in human tumor xenografts, and this is one of many examples. There are tens or hundreds of papers. And there is another important thing. Increasing dose favors your nanoparticle, at least in the case of doxil, over free doxorubicin. As you see here, when you give a low dose, the delta in the tumor concentration between doxil and free doxorubicin is very small, but when you start increasing the dose, there is a linear increase with this doxil formulation that you don't see with the free doxorubicin. So in the end, you get a much greater delta. So all these things have a lot to do with those things that I described to you before of convection, and it definitely seems that the Cmax concentration that you achieve, a maintained Cmax, high Cmax concentration of liposomes, is very important to get a significant push of convective transport into the tumor. By the way, even in brain tumors, you can see that doxil concentrates beautifully following the EPR effect. You can see here with Evans blue that this is a hyperpermeable tumor. Unfortunately, when we lose the battle against brain tumors, it is mainly due to areas of the tumor that are brain adjacent to normal tissue, in which the barrier is much less efficient. The EPR is much less efficient than in the tumor itself, where there is active neoangiogenesis. And as you see here, doxorubicin hardly accumulates at all in these brain tumors. Now, you will very well know that the blood clearance is critical. You have already seen that convective transport and diffusion also will depend a lot on how well can you maintain a high concentration of liposomes in the intravascular compartment. And indeed, this is from a paper of Dr. Ruth Duncan, and this compares various carriers of doxorubicin, doxil, HPMI dox, and dendrimer with doxorubicin and free doxorubicin, and you can see that the highest concentrations in tumor are obtained with doxil by far. So I think it is important to remember that, and when developing new systems of delivery, at least when you work with anthracyclines, your comparator should be doxil or a similar formulation rather than using free doxorubicin, because what we need is only to make things even better and not go back and compare to the old drug. And what happens in humans? Well, in humans, stealth liposomes, as I have already seen, as I have already shown to you in Kaposi sarcoma, stealth liposomes do seem to accumulate in tumors, but it is by no means, I would say, a complete effect that happens in all cancer patients. It is in some tumors, like head and neck cancers, which are very inflammatory tumors, there is huge concentration of liposomes. This was described by Harrington and Simon Stewart about 10, 12 years ago. And this was done still with old radionuclide imaging results. These are results that we obtained from patients who underwent surgery after doxil administration. 7 days after doxil administration, we were able to measure doxorubicin in a bone metastasis of a patient, and the concentration was 10-fold greater than that seen in muscle. So this was a good opportunity to see the selective concentration in tumor in humans. There is also another important effect that has to do with the tumor size dependence, and this has been shown for polymers and for liposomes. When the tumor increases in size, the concentration that you achieve with your nanoparticle or your nanomedicine goes down. By the way, this is hardly affected by, in the case of free doxorubicin, you see hardly any change. So again, these are significant differences between nanomedicines and free drug that probably are related to the EPR effect that is a much more decisive factor, biologic factor for nanomedicines than for free drugs. And this is another example from Merrimack Pharmaceuticals, in which again, now you can see not the concentration in tumor, but the biological anti-tumor effect. The decrease in tumor volume changes as the tumor uptake of the liposomal drug is better. So clearly, what this is leading to us is to the fact, but just a concluding slide on what the heterogeneity of EPR effect and many of the factors that you see here that have an impact on what the EPR effect is going to be. And I do have a couple of slides just to show you a couple of interesting papers that have shown all other factors that are important in considering the EPR effect. The normalization of blood vessels, which is actually obtained with bevacizumab and other anti-angiogenic agents. In a recent paper of the Rakesh Jain's group, they did show that when tumor blood vessels are normalized using anti-angiogenic agents, actually the abnormal blood vessels will actually improve the delivery of small nanoparticles. However, they were hindering the delivery of large nanoparticles. Therefore, this is interesting. There could be some anti-angiogenic agents can sabotage actually the delivery of some of our nanomedicines, especially if the size threshold of these nanomedicines is relatively large. So this also has to be taken into account. And the other thing is that prior treatment with various chemotherapies and even with liposomal chemotherapies can also dramatically reduce the EPR effect by normalizing the blood vessels, such that when you give a second treatment, you may not have the great large delivery that you get in an initial treatment. And another important thing that is now also becoming very critical, not only on the anti-angiogenesis treatments, but also may have an impact on EPR-mediated therapies, is what is called co-opting blood vessels. And it turns out that many metastases are actually, in many metastases, the tumor cells seep around the normal blood vessels, and they utilize the normal blood vessels as their primary supply of oxygen and nutrients, such that the EPR effect can work better in the primary tumor and less effectively in metastatic tumors. And my time is out, but I will skip these images, which were lent to me by Dr. Thomas Andresen on PET. But clearly, just in 2 words, I will say that this is clearly the best way today to look at distribution of nanomedicines, and a study done in dogs by Dr. Andresen shows again that also in spontaneous dog tumors, some reach very high SUV values, but others do not have the same. In 4 dogs there was substantial accumulation, but in 2 dogs there was no substantial accumulation. So recent, and maybe this I think will be one of my last slides, is we also already know today that even by PET imaging there is variability of EPR effect in humans. And Merrimack Pharmaceuticals, in a breast cancer meeting this year in Impact 2014 in Brussels, they did show a poster in which the uptake of a liposomal radio-labeled Cuprum 64 labeled liposome showed in tumor lesions a variability going from 0.7 to 11.5% injected dose per kilogram. So this is telling us that probably it is very important to monitor the EPR effect in humans, and perhaps nanoparticle-based therapy should be guided by images analysis of nanoparticle biodistribution. And of course, a key question is there a correlation between nanoparticle localization in tumor and anti-tumor response in individual patient? Therefore, I think one important thing is to do, but yeah, actually I'm over if I look and my time is 0. But anyway, a very important thing is, I'm minus. Okay, so I will just conclude by saying that it is very important in preclinical and clinical models to really have a companion imaging study that will tell you how effectively are you targeting your nanomedicines to cancer patients. So thank you very much, and this is a list of my collaborators in these studies and other studies. Thank you, and sorry.
Thanks a lot, Alberto. We will subtract the overtime from the next talk in 2015. Are there questions regarding this interesting topic? Please.
Hey, thank you so much for a great presentation. I was wondering why the drug accumulation decreases in the tumor when the size of the tumor increases.
This is due to the fact that the distances between blood vessels and tumor cells, there are fewer blood vessels. The blood vessel density decreases. The tumor usually, there are hypovascular areas, there are hypoxis areas, and as tumors get larger, also the interstitial fluid pressure goes up. So a combination of all these factors, a decreased density of blood vessels and hypoxic cells that are far from blood vessels, plus a high interstitial fluid pressure, decreasing the convective transport of liposomes into tumor fluid are the reason for that decrease.
Yeah, Alessandro, please.
Yeah. Thank you very much. I am here. Yeah, this side.
Yeah.
Okay, good. Thank you for your presentation. I think this topic is always very relevant, and particularly is relevant the last part of your talk when you describing the possibility to put together imaging and therapy. This is important for two things. One is to measure the EPR effect from one side, and from the other side is how we can modify the physiopathological state of patients when the EPR effect is not so favorable. So two very important things, and the missing of tools that enable us to understand the patient state limit the use of nanomedicine today. So can you comment this?
Well, I fully agree with you. First, I think, as you pointed out, there could be theranostic, but not necessarily. We could use a companion imaging agent which has the same composition as and structure and physical-chemical characteristics as the drug carrier to get an idea of what is going to happen to our nanomedicine. And secondly, yes, I fully agree with you. There are many pharmacological agents that may have an impact, sometimes a positive, sometimes a negative impact on the delivery of our nanomedicines. And again, having a companion imaging agent can help us to know what is going on.
One last question, please.
Thank you. So actually the EPR usually is considered more of the penetration, but you emphasize also the retention. So might be that actually we need to treat it as a two different phases. I mean, in one phase maybe it is more permeable, but the retention, for example, is enhanced later than.
Well, I think they are inseparable, but I do believe that if there is an additional effect of the targeting of the active targeting of a nanoparticle, as I mentioned, it is the fact that by increasing the binding of your nanomedicine to a receptor inside the tumor, you are decreasing the possibility of drug washout from the tumor, because this apparently does happen in many instances. So you may be losing drug before it diffuses into tumor cells. So some people have definitely shown that even if the circulation time of some actively targeted nanoparticles seems to be shorter than the plain nanoparticles, still the concentrations in tumor appear to be comparable. So, but I mean, this is all what I can say about it. You can definitely modify both permeability and retention, yes.
Okay, then thank you very much again, Alberto.